At this time, I'm going to turn it over to Maria Strepel-Turo, the co-director of MHTTC. Again, welcome.
Thank you so much, Nan, for that wonderful welcome. And good afternoon, everybody. Bienvenidos. My name is Maria Strepel-Turo, and I am the Director of Health, Equity, and Belonging at the Yale Program on Recovery and Community Health, as well as the co-director of the New England Mental Health TTC. And it is our pleasure to be welcome you and to be celebrating Pride Month with you all. If this is the first time in joining us, I'm just going to tell you a little bit about what the Mental Health Technology Transfer Center stands. Next slide, please. This is a national network, as we acknowledged, funded by SAMHSA. And in each region of the country, and I notice a lot of you come from all over the place, which we are delighted to have you here. Each region of the country has a mental health TTC technology transfer center. What that means is that we are, our goal is to provide training and technical assistance free of charge to anybody in our regions. In this case, we are in region number 1, which is the one that we have here, but you can see, so I encourage you to be connected to the network. We do provide all kinds of trainings. Everything, again, is on the website that you can look it up. And we also provide intense technical assistance or targeted technical assistance for groups that are interested in further their knowledge and expertise on various topics. So feel free, at the end, you will have how to sign and receive information about all our upcoming events. Next slide. So for our area, the New England one, the New England Mental Health TTC, as it says at the beginning, is a partnership between the Harvard Department of Psychiatry and C4 Innovations, which today we are going to be partnering with to bring you this amazing event. In our region, we are completely committed about enduring and doing in everything we do the resilience and recovery principles. We believe that mental health must provide resources and skills and information that are going to promote resilience and recovery that's based on respect, that emerges from hope, that is family, person-driven, especially culture that takes into account who we are, where we come from, and it's very much influenced by that. And this is what this workshop is extremely important for us. So please check out our principles of recovery and resilience. And in addition to the principles, next is this seminar is part of our series, our initiative called REACH, which is about racial equity and advancing cultural humility. We do have offered constant events, and as I said, we not only provide training, but we also provide technical assistance for programs agencies who want to implement those principles of racial equity and want to advance practices. So it is my pleasure today to really introduce you. As we do know, transgender people experience higher levels of depression, anxiety, suicidality than cisgender people, and at the highest rates of mental health challenges among the people who identify as LGBTQIA+. It is my pleasure today. I want to introduce a dear collaborator for us, Lee Lockhardy, who will be setting up the stage for today's session and will introduce all the amazing speakers that we have for you. Lee is the Operations and Technical Assistant Coordinator at C4 Innovations and provides technical support for C4 staff, partners, and participants on a variety of platforms. They ensure that meetings, courses, webinars utilizes the best practices and that staff and partners receive responsive and efficient technical support. Lee is passionate about bringing their lived and living experience of the recovery and non-binary identity to their work and their community in the hill towns of Western Massachusetts. So Lee, it's my pleasure to turn this amazing webinar for you today.
Thank you so much. I appreciate everyone being here. This is my first hosting, so I'm very excited to share this opportunity with all of you. And thank you again, Maria, for those kind words. Just to set the stage for us a little bit, this Pride Month is a bittersweet one, as we unabashedly celebrate the joy and beauty of LGBTQIA+ and trans existence, and draw attention to the ongoing attacks on transgender people across the United States. Getting out of bed each morning can feel like an impossibly heavy load, but in every town, state, and country, transgender people are doing just that, continuing to show up and create community for their kin. So it is with great pride indeed that we gather here to share the incredible work that grows throughout New England, offering hope and ensuring dignity for people of all experiences. Let's take this time to listen, learn about challenges, and imagine a supportive, safe, and liberated future together. As ever, remember that the first Pride was a riot. So what we'll do now is we're going to go a little bit into our speakers for today's event. Oh, there's me again. Forgot that one, sorry. But today's speakers, we've got Layne Alexander Gianakos, Heather Kim, and Kirill Ivan Staklo. And we'll start with Layne, talk a little bit about what Layne does. Layne began his work as an organizer and advocate for the LGBTQIA+ community in 2006, working with GLSEN of Connecticut and becoming their inaugural student board member. Throughout a variety of platforms, including syndicated television, public appearances, and meetings with educational and political leaders, he was able to inform others about the importance of LGBTQIA+ safe educational spaces. In 2015, he received a bachelor's degree in psychology from Eugene Layne College, the New School for Liberal Arts, and began a career in the nonprofit sector, centering LGBTQIA+ people and their experiences. He has done a wide range of work as an outreach specialist, HIV tester, care coordinator, case manager, and director of programming, and used a variety of positions to establish LGBTQIA+ informed and inclusive healthcare settings across Connecticut. So we've got a very strong Connecticut crew for us here today. Currently, he provides health equity trainings focused on LGBTQIA+ cultural safety and anti-oppressive frameworks for healthcare providers, managers, and institutions. He's also the program coordinator for the newly formed Office of Health Equity Research within Yale School of Medicine, where being a part of a larger system aids him in addressing health disparities for all marginalized populations, particularly in the New Haven area. So thank you, Layne, for joining us today. And we'll get just a little bit for you in a moment after we finish introducing our other two presenters. I know this is a lot up front about them, but they are so fantastic. I can't stop. I'm going to tell you all about them. Heather Kim is a psychiatrist at Massachusetts General Hospital's Gender Identity Program, specializing in working with trans and gender diverse patients and their families across the lifespan. After receiving their MD from Medical College of Wisconsin, Dr. Kim completed their adult psychiatry training at Duke University Hospital, where they created a psychiatry rotation dedicated to transgender health and served as the chief outpatient resident. They completed their child and adolescent psychiatry training at Yale Child Study Center and also helped to formalize the transgender health elective for child psychiatry residents at Yale. Dr. Kim is currently a clinical instructor at Harvard Medical School and writes about gender-affirming care, trans-specific topics in psychiatry, and informed consent. And our last speaker today is Kirill Ivan Staklos from PeerPride, also in Connecticut. And Kirill is a peer support programming specialist with expertise in LGBTQ+ peer support, crisis, and suicidality. And along with the team at PeerPride, they offer services such as curriculum development, equity assessments, consulting, cultural competency and humility training, and crisis and peer support service development to folks in Connecticut and beyond, all over across the country. And also run a program called Transhaven, which is PeerPride's first Connecticut-specific community-run direct service program. And Transhaven is a space that proudly builds Black and Brown trans power, trans immigrant power, trans youth power, and safety and self-determination for the most vulnerable people in our community through support groups, social events, advocacy, ID change support, healthcare navigation support, and much more. You name it, they are working on that in the New Haven area. And so before bringing together the PeerPride team, Kirill spent 6 years building up the only international trans peer support and crisis hotline program at Trans Lifeline. And he is active in international LGBTQI plus Roma community work. So please join me in welcoming our esteemed speakers today. And thank you for joining us in our event. So what basically want to hear from you today is, I just did the official biography, but if you want to share with us a little bit about the work that you do in every day and also across advocacy, mental health, behavioral health, and just give us a taste of what it is that you do in everyday work. So Layne, if you don't mind, I'll call on you first and let us know.
Sure. So when it comes to addressing transgender care and mental health, predominantly my role right now is training healthcare organizations and providers. They have a lot of questions about transgender competent care when I present, but there is always a very strong emphasis on mental health care. Even for those that provide primary care, it just cuts across all continuum of the care transgender people need. For a long time, when I did case management, I was responsible for making all referrals for an LGBTQ health organization to mental health care providers. And one of the biggest challenges I saw was not just the competency of providers, but the shortage of providers that had that level of competency. When you add in people who only accept certain insurances or only in certain locations or do telehealth versus not telehealth, it becomes trickier. So something that I really emphasize is training our current cohort of mental health care providers to better able serve trans people and address that shortage. As far as my work at Yale School of Medicine, predominantly we work on racial and ethnic health equity, but we do address health equity needs across the continuum. At the Yale School of Medicine Office of Health Equity Research, we use methodological cores to help other offices within Yale when they intend to do health equity research as well. We work very closely with community organizations across New Haven and the rest of the state to address health disparities, for example, pediatric asthma. And we actually have a program, and the next identified disease of focus is mental health. So I'm pretty excited about that.
Sorry, I had to unmute myself. That was the face I was making for that. Thank you so much, Layne, for introducing yourself and for telling us about your work. And we'll move on to our panelist questions in a little bit, and hopefully we can get some good discussion going. But for the time being, I'll also transfer over to our next speaker, Heather Kim, who's going to be telling us a little bit more about their work at Massachusetts General Hospital.
Hi, I'm Heather. Thank you so much for the lovely introduction. Happy to be back at Yale. I'm a regular degular psychiatrist. Most of my work is seeing patients, doing medication management, and because I'm one of the few people with the identified focus on working with trans and gender diverse youth and their families, that tends to be a lot of my patient population. And outside of that, it's been a lot of teaching medical students. So I help teach the LGBTQIA course for Harvard medical students. They also get to rotate with me. They get to see that outpatient psychiatry isn't so scary. I've also mentored residents who are interested in providing this care. And I think the really exciting part is a lot of young clinicians that are coming up are really interested in learning about it. They're much more competent and more familiar and comfortable with the material than a lot of the older psychiatrists and older doctors. So I hope that all the shortages that Layne and we're all experiencing are going to get better. Then outside of that, most of my scholarly work is around more trans-specific topics. I feel like there's a lot of wonderful resources in making the environment or making mental health care more trans-inclusive. But what's really lacking, even more than those things, are trans-specific resources. So how should we think about medication management through, if someone is starting gender-affirming hormones, if someone is going to be going through surgery, how do we best adapt manualized treatments, therapeutic approaches specific to trans and queer populations. And I get to write about that and teach about that. And I also like to think a lot about informed consent and how do we move away from a assessment-based gatekeeping model that has done like so much historical harm to trans and gender diverse patients. But that's kind of my day-to-day.
Oh, thank you so much. And I know that informed consent is also shared under the interests and pursuits of our next speaker, Kirill. So I hope that we can continue our conversation about how that comes into this work, but handing it over to Kirill about his work at Trans Haven and also PeerPride. You want to tell us about, I mean, obviously we've got a big Connecticut contingent, like I said, but a little bit more about that on the ground work in Connecticut that's going on.
Yeah, for sure. Thanks for having me. Thank you for the intro. I'm Kirill. Yeah, so I think the things that end up overlapping a lot between the two areas of work that we do at PeerPride, right, between consulting for best practices work and Trans Haven work here in Connecticut, is addressing the amount of trauma that comes from a lack of competency, specifically in mental health. And the area that I focus on myself professionally that's not trans specific, but ends up being trans specific a lot of the time, is informed consent, specifically in crisis related care, and navigating ways to avoid non-consensual interventions. So I identify as a autonomy oriented suicidologist professionally. And a lot of the work that I do is actually not with organizations that specifically serve trans people, but because of the types of impacts that we're looking at, the threats that come from non-consensual institutionalization, the threats that come from police involvement, the threats that come from lack of competent care in crisis situations specifically impact the most marginalized communities the most. PeerPride happens to be an all trans team, even though we have a lot of different people that have a lot of different competencies as consultants, but we do often get hired to talk about trans specific things, you know, because people, I guess, expect trans people to bring transness into everything. And that's been a lot of our professional history as consultants as well. So Trans Haven started because there was a need. We did not plan to start Trans Haven. What ended up happening was one of my colleagues started getting hit up a lot by a lot of trans kids in Connecticut, and being like, is there a way that I can just reach you directly? And like, is there a place that's just trans run in Connecticut where I can get support and stuff? And my colleague was like, well, no, but I guess there will be in a second. And we realized that there wasn't anything like that in Connecticut. So because we happen to be an all trans team and we have, you know, a very large presence in Connecticut on our team, we decided to create Trans Haven, which to my knowledge right now is the only 100% trans direct service organization in the state. Maybe Layne can correct me on that. Maybe there's something else that you know about. But we keep getting told by people that we are. So, okay, I trust that. Yeah, so a lot of the work that we do that pertains to mental health is on one side advocacy and education for people who provide mental health, crisis and peer support services. And on the other side is how do we safeguard the mental health of our community, right? And the answer to that a lot of the time is not to talk about mental health. It's to create better material circumstances for people, right? Ensuring that people have access to safe housing that's not transphobic, ensuring that people have access to a job that's not transphobic, ensuring that people, you know, have trans community, which is one of the most important factors for trans people. So for example, the groups that we run are not support groups, they're social and hangout groups where people can hang out. So that's our orientation. I'm happy to talk more about our work in the future, but yeah, I'll stop talking now.
Thank you so much. And I appreciate, I know that was a bit of a general, idea, but I hope that a couple of these questions might get some more specific topics that folks can understand in their work. But I wanted to ask all three of you, and feel free to answer or not answer. We can go through about what are some specific mental health needs that you've seen specific to the trans community. And I know we mentioned a few of these in our introductions, but if there's any areas of practice that you've seen growing that you're particularly excited about that have come up during your work that you're most interested in continuing to see grow. Anyone want to start off, or?
I can
Something, no, go ahead.
So I think one of the things in terms of mental health needs that I see is even just like getting into the clinic, because we live, in the US where most of us, depend on an insurance, be able to access care, that I've had a number of patients recently lose their coverage either because they lost their job or their parents changed their jobs or lost their job or aged out of the insurance system at age 26. And add to the fact that, trans people experience job discrimination. A lot of the times people are forced to work outside of like the above ground sort of like regular economy. That it's, when we focus on just the mental health needs of like making mental health like a better environment just in the clinics, I feel like we're missing so many of the populations who can't even get in the doors. So that's the thing that's been on my mind recently. But in addition to that, I feel like there's still a perception that taking care of trans people is this like magical thing that you can only know after like many years of learning, or that this is only like you can only be expected to care for these populations if you are trans or if you're queer yourself. And so even when people get into a general clinic, I feel like there's this like long wait list of like, well, this is our one specialist who's going to be able to see you, who that we can maybe even vaguely guarantee that you're not going to be traumatized by seeing this person. And I suppose the one positive that I can think of is that, as I mentioned, there are more young clinicians who are coming up who are interested in this care and are more confident. And obviously with organizations like Kirill is running, there's lots of community supports that are kind of coming up in place because of such a lack of appropriate channels in like the mainstream sort of ways of getting mental health care. But I don't know if that's a good place to just pause. I feel like I'm rambling at this point.
No, that was wonderful. Thank you. I appreciate that. And yes, so I definitely want to frame that for everyone who is attending, in that it is just general human rights that we are proposing for folks. And, if there is a good baseline of those human rights and those rights to housing, to, safe place to work, and all those pieces, that then mental health can even be starting to discuss. And I agree that there are a lot of barriers to entry for folks. And I am so thankful for the work that you're doing, all of you, in kind of making that more, obviously there's systems that are in place, but in your individual time, making that a more possible thing for folks who might be trans or gender nonconforming, and also just anyone who needs assistance. So I know, Layne, you started to answer that one. I just wanted to give you some space if there was anything you wanted to add in after Heather spoke.
Yeah, I'm also really excited to see these new groups of providers entering the workforce that have an interest in gender affirming and informed care. In some ways, it's a double-edged sword because there isn't really a codified system by which they are trained in this. Anybody can become a provider and check off the box and say they're trans competent. And I have seen firsthand that that's not always the case. That being said, there is the interest and people seeking out education, and I have seen more and more recognition of when people can see their limitations with care. especially trauma-informed care for trans individuals. So I see the workforce changing pretty rapidly, month by month, I would even say, and that's something that excites me a lot.
Thank you so much for sharing that. And I was just going to talk about trauma-informed care, so we'll skip that one for a little bit. But I wanted to go for some, it's a little bit of a simpler question, but how can mental health providers create a safe and affirming space for trans folks that can be, like we were saying, in physical spaces, if you're meeting in, more of a formal setting, or in online spaces, like you were saying, Kirill, how can that be best in place? I know that for my work, we have been just trying to sneak pronouns in every single place we can as a simple but effective way of starting that off. But I wanted to open it up to all three of you to discuss any other kinds of ideas or strategies that you've seen used. And maybe if you have some that aren't so helpful, you can feel free to share those too.
This isn't really like a tips and tricks type thing. I guess I can start with a tips and tricks thing. Especially if you work in a larger establishment, it can be really, really helpful to look at and challenge the way the documentation works in your establishment, right? If everyone is being dead named and misgendered throughout all of their paperwork, and everybody who comes across their information or their file is going to dead name and misgender them, and they're going to have to out themselves in order to access care, it's not going to be a very positive experience or very conducive to improving their mental health. And that'll just be another reason why they are less likely to access care in that space. So that's an easy thing. I think a harder thing that is less about, practical solutions around like looking at your paperwork, right, is I think that, and we can talk about this more in depth, but I think that mental health as a field, in fact, I know that mental health as a field has a really, really nasty history in terms of how providers have been empowered to pathologize transness. And it's still something that continues. And with the new iterations of the DSM, it might be claimed that it's not continuing. However, the history is still there. And the history is still there in the W path. And the history is still there in how insurance approaches people being able to access care. And ultimately, it's a lot of work. And it's a lot of self-awareness that it takes to really divorce yourself from this idea that you are in a position to tell somebody who they are or are not. And unfortunately, right, like Layne was saying, there isn't a uniform training or any kind of uniform education on that simple fact that you don't get to tell somebody what their gender is or isn't. And the history of mental health says the exact opposite, that you do get to tell them that. And only recently have we been seeing shifts in how people are taught, and that's still insufficient and it's still pathologized. So I think it's important for us to acknowledge this culturally as a field, that there are things that are antithetical to trans people's self-determination within the way that we're educated and within the way that we're expected to practice. And just really, really work hard against that in the relationships that you build with your clients.
Thank you. Yes, and that speaks to also the reach, this whole area of the work that we do under MHTTC with cultural humility and understanding that, yes, the white supremacist ideology of being the right one to tell everyone exactly what is correct and what is the right way to do things is definitely one of the things that we're working so hard to disrupt in the field of mental health and behavioral health, and also in recovery. So I want to thank you, Kirill, for bringing up, right? It was a question that I know has a lot of implications, but I appreciate all those little complexities that you teased out in your answer. So thank you so much for that one. I also, under that same kind of purview that we're looking at for race equity and cultural humility, I know that organizationally we are tied to systems, and there might not be that much room for movement in that. But as far as in your personal work or your personal advocacy, how do you ensure that the voices of trans folks of color are centered in the work that you do? That's okay. We can skip that one. No problem.
I mean, I can answer, easy answer. Most of our org is people of color and all of our org is trans. I just didn't know how else to answer that. But yeah, like we look at the intersections of lived experience and don't assume that all trans people have the same lived experience. It's just hard to answer because we are a majority BIPOC, all trans groups. So yeah.
Completely. I
Yeah.
wanted to make space for Heather or Layne if you had anything to add.
And in the scholarly work that I do, we've been, like me and my collaborators and the folks that I write with have been really like trying to be mindful of doing research or like, you know, looking to the community to say like, what is the research that's actually needed? What are the gaps that are there, rather than, you know, having like people outside of the community come in and say like, oh, we would like to study this aspect and, you know, potentially contribute to greater stigmatization. I recently got to write a chapter for an all trans and non-binary and gender expansive authored textbook, which was really exciting. I think that was the first of its kind for the American Psychiatric Association. So I think having those like people who are part of the community and also like partnering with the community if there is research to be done to actually address things that people want, rather than, I don't know, doing studies that could be potentially like contribute to just more eugenics down the line. I think that's a pretty important thing to have in mind if you're a researcher.
Yeah, thank you so much for bringing that piece in there. I know that research is equally that piece coming in. And I wanted to ask one that is, you know, maybe a little bit more personal, but feel free to answer or not answer according to your comfort level. But I wanted to ask about how you bring your lived experience or your previous experience with mental health providers into the work that you do. I can share for myself that being, I've worked in schools and then also in C4. I do a lot of work across technology, but bringing my lived experience in my ability to meet everyone where they're at has been so key for me to learn just how to treat other human beings with empathy and try to understand that they might also be having a very challenging day. That's a simple one, I know, but I'm interested to hear a little bit more about how you bring your lived experience, if you do, into your work.
Well, I always say it's pretty eye-opening when I struggle accessing care for myself, when I'm supposed to be the person in the position of power to help other people access the care that they need. I encounter the same barriers that the people I work with encounter, finding trans and trauma-informed care. I can speak to the state of Connecticut. There's currently no intensive outpatient program that I would say is trans competent. And that has been quite a challenge when making referrals. I've experienced that firsthand myself. There used to be a queer IOP, but that was shut down. So there's just a lack of resources. And I have a lot of empathy for that because I've experienced it myself.
I can totally agree with you on that. I thankfully have very strong health insurance through C4, but getting myself to that place to get providers and to go into that space is often still, even though I know there are amazing providers out there, it can be very intimidating to make that kind of move for the first time. I know they say that picking a mental health professional is kind of like speed dating, but it really feels high stakes sometimes when you're going out there on your own. So thank you so much for sharing that, Layne. I'm totally in agreement with you on that.
And just to add to the insurance piece, I mean, I work for a major institution and I pay an extra approximately $200 a month to receive the type of insurance that mental health care providers accept. If I accepted the lower cost healthcare plan through my employer, the amount of people who accept that insurance eliminates by like 80%. So it's also a cost barrier for a lot of people in addition to an insurance barrier.
Completely. And thank you for pointing that out. I appreciate that. Did anyone else want to add on to that? Oh, we got a kitty. Yay.
I also have a kitty, but I'm oh yeah, I can carefully display him. There he is. Lived experience. I think that it's impossible to divorce your lived experience from the work that you do, especially when you're working with your own population. But even when you're not, right? Yeah, I think for me, my experiences with inadequate and very dangerous response to crisis and suicidality is a big galvanizing point for me in the work that I do and the advocacy that I do. I would definitely second everything that Layne said. It is definitely both a lot easier and very difficult when you're assisting people with navigating the same things that you struggle to navigate. So with both mental and physical health care, a lot of the time the support that our team members provide people is, not the typical case management or referral type of work that they'd see somewhere else, but more of a conversation of like, oh yeah, I've been to this place. You can go to this provider there, but don't go to this other provider. So when you call them, you have to request this specific provider, because if you get the other one, they're going to gatekeep you. Or like, this is what you can say to this particular person to get a letter for surgery. So it's a lot of, a combination of knowledge of the systems themselves and also community hive mind knowledge about where are safe places to go. And because, again, with the pathologization of trans people, gender affirming medical care is so intrinsically tied to mental health care, because there are requirements for access to mental health care in order to get green lighted for a lot of gender affirming healthcare. There's always that barrier for people. So if there is not a competent provider or an accessible provider or an affordable provider, then not only does your mental health care get impacted, your physical health care gets impacted as well.
Yeah, and I appreciate you bringing in the peer piece. I know that is hugely important to the work that we're doing as part of New England MHTTC, because recovery and peerness goes hand in hand. So thank you for highlighting that as well. I wanted to ask a little bit more about that as well, in case that is something that you may have experienced throughout your work. I know that Kirill specifically, you have that piece, but I know we're speaking about mental health, but also in behavioral health care, just thinking about how can people best support behavioral health and recovery. Oh, Maria had a question. Maria is the co-director of New England MHTTC, so I will totally allow the break in there. This is also a great question. Can you possibly provide an example of gender affirmative care, what that would look like, maybe from as a person enters into a service?
Does anybody else want to answer? Or Layne, I know you do this every day. I'm tired.
Yeah, I think you brought up a really good point with the letters. Not everyone realizes that to receive gender affirming surgeries, you are required to get certain letters from mental health care providers. And there are some providers who are not prepared to write those letters, or who will require, X amount of sessions in order to feel comfortable enough to write those letters. An example of gender affirming care would be someone who is familiar with these letters, knows the language to use so that insurance will accept it, knows the risks and benefits, is able to explain that to their client and allow them to make their own decisions with regard to the surgeries they choose to get.
Thank you, Layne. Yeah, and I know we have another question kind of on that same. I know that a lot of the language can be complex to get into as you're starting out, but gatekeeping can be, if I can take this one for y'all. Gatekeeping can be a way to keep folks who might need services out of services by either just not answering in their questions, or by providing services that do not meet their needs so that they are not able to continue utilizing those services. Dead naming is an example of if someone has a name that is different from their birth name or dead name, depending on how they define it. That is a way to specifically misgender and entirely make, what's the best way to say it? It's a terrible thing to do. And it makes trans folks, relive some of the most traumatic places that can be in their memory, and, invalidates who they are as the person that they are, and kind of adding in what affirmative care is, the difference between something that is very, this is what you were born as, this is exactly what you're going to get. Affirmative care is understanding the person, their identity, and what they bring with them, their experiences, yes, but using the name that they use, and attempting as much as possible to make sure that, like you said, Kirill, that papers, policies, and procedures all reflect the names that folks choose, that your legal name is just one piece, and that there are a number of barriers that keep people from changing their names legally, so that there is a lot that goes into making care affirming, but these are some things that can be specifically not done to make care more comfortable and better for trans folks. I hope that is answering a bit of that off the top of my head, but that is a very good question, and thank you so much. Thank you, Natasha Chopra in the chat, sending a resource if you are looking for some of those definitions. PFLAG is a great resource for those as well. And just taking a second, thank you so much for all of those pieces that you brought to us. And I wanted to also talk a little bit more about, as I mentioned earlier, that it's a tough time in the United States with the general small consensus that is quite loud and very politically active and legislatively active. It can be overwhelming to face that and show up in your work and also be there for others. So I think I was going to, ask about how, if you feel comfortable sharing, how you take care of yourself and how you prioritize your mental health, even in times such as this, when it can be very challenging to continue doing the work that you're doing.
I mean, I won't lie, I'm really bad at this one.
Me too, 100%.
Yeah, I always try to prioritize the people coming to me for help, and then neglect my own needs. But I have gotten better at it, and a big part of that is just having the introspection to know when you are getting burnt out, recognizing the warning signs before you do get burnt out, and having a better idea of what you need to avoid burnout. And that looks different for all people. For me, it's often just unplugging for a little bit and, going offline and being with loved ones, doing things that don't require me to constantly think about the state of the world.
Yeah, thank you so much. That I'm right there in agreement with you. I generally don't read the news too much, but if there's knowing people in your community and knowing that you can have safe people to talk through things like that, as opposed to reading obviously a mainstream media perspective can sometimes be really helpful. I just want to make space also for anybody else who wanted to talk about that.
In my clinical work, I find that it's really helpful to have like a good group of other clinicians working with trans folks who are queer or trans themselves, who are also clinicians, to like talk through cases with. Because a lot of folks that I see are facing a lot of difficulties, and oftentimes we just kind of sit in session being like, damn, I wish I could prescribe you a house, because like this is the biggest thing that's going on in your life, or I wish I could prescribe you a different family. I wish they weren't just like so rejecting. And there really comes so many times where we just kind of sit there feeling powerless. But having, you know, these peer supervision groups, I mean, it's just helpful for like just clinically difficult cases, for like medically difficult cases, that you have like other, you know, experts or like other clinicians who have maybe more experience, or like who also have experience to kind of talk these cases through. And also for yourself to be like, yes, like you are kind of doing the right thing. Like this is the best that we can do in this moment. Or sometimes people do have like magical resources that they're like, oh, have you thought about this? Did you know that there's this grant that you can apply for? That I find super helpful. And I make time for that specifically on a weekly basis. And just like Layne said, just unplugging, not like doom scrolling. This was really helpful. This came up in peer supervision as well, where kind of constant looking at stuff that makes you feel bad, that you know is going to make you feel bad, like all these like really, you know, despondent sorts of reports, or like awful things that happen. I know they happen, like we live in this country. Like that in and of itself can be a form of trauma response, to like constantly re-traumatize yourself to that. So that was a helpful way for me to understand like that what I was doing wasn't really keeping up with the news or informing myself, but just like a really maladaptive way of trying to cope. I've also been able to share that with patients, which was kind of helpful for them to kind of reframe it. And the other one of my patients also brought up that for them, they felt like their kind of endless media consumption that made them feel worse was a form of self-harm. So kind of being able to take that sort of perspective, I think, is helpful. You know, outside of that, all work is burnout inducing, all work is alienating. If you can organize that work with other people around you to make your like material conditions better, I think that's great. But if you can't, if you're, you know, in private practice, or if all you do is see patients in the clinic, then maybe you can at least have a peer supervision group.
Yeah, thank you so much. Thank you, Heather. Also, I would just add in, I know we've already seen 2 kitties, but my very much taking care of myself is when I don't even feel like I want to get out of the house, or I don't want to face other people, at least taking my dogs out is like my go-to. I know that cats don't generally go for walks. Maybe yours does, Heather. I don't know how special our cats are, but just getting out and you know, doing that for a creature that might not even, you know, have its own way of speaking for itself, can sometimes be my go-to to, you know, just disconnect, right, and take a step away from the computer. And I know that is an answer for anyone who has, you know, burnout or is running low on energy when they're at work. But I find that having that kind of like animal empathy in my life is also incredibly helpful for me. So I wanted to add that in there too, and make space. I know, Kirill, if you wanted to add anything, or if not, that's totally okay.
No, I can add something. So I know that for those of us that do a lot of work, like a lot of the solutions about just like, oh, like leave work at work and, you know, don't even think about it is impossible, especially when we are working with people that are directly impacted by the speed of our response, right? So my solution to that is I've stopped challenging myself to stop working forcibly. And I've started challenging myself to switch gears in what work I'm doing. So for example, if I'm finding myself experiencing empathy gaps when I'm talking to people that I should be providing support to, because I'm tired of talking to people and I just want to pet my dog. Maybe instead of working up my anxiety about if I don't do anything right now during a time when I'm supposed to be working, I just start petting my dog and not doing anything. What if I switch gears and do something else that I've been neglecting in my work that has nothing to do with the thing that's been burning me up, but will still be productive? So I like to challenge the solution that gets thrown at people a lot, to just like not do anything and go take a bubble bath, because A, for those of us who have to work to survive, that might not be possible. A lot of us have to work a lot in order to survive. And B, those of us who work to serve other people see the direct impacts of our work, and it can be very, very stressful to fall behind. So that's kind of my solution for it. And I also listen to the people around me that I trust. If somebody is telling me that I seem off or something like that, I trust them and I see what I can do for myself. Yeah, those are the main things.
Thank you. I love that solution for, doing something that I don't, we, at my work, we call it, deep work or administrative work. We try to make space for it. I know that one of the things that we do at C4 is having Friday afternoons after 1 p.m. try to be for that kind of work, and getting yourself ready for the next week is something that you don't often get to, right? You're always ready for like the next thing that's coming, but there's very little time to prepare in terms of that. So that's one thing that I can share that we have very much appreciated in the work that I do, in that can be something that if you talk to your colleagues, might be something that's possible just to work out amongst yourselves and not have to be obviously a huge game changer. But that is one that I wanted to point out too, that I appreciate all of your tactics and strategies for yourselves and for others, because I think that it is applicable to everyone, but also specifically to folks who are working in situations that might be re-traumatizing to them. So thank you so much for your answers to those questions. And I think we're going to open it up to folks. If you have some questions, I know we've had a few come through, but we are opening it up. So if you'd like to raise your hand, if you have a question to ask, then we'll be able to unmute individuals. And yeah, we got the first one coming in right here. So I can pose that for our panel. It's from Teresa Boyd. Thank you, Teresa, for sending in your question. And that is, could you expound on how you define trans competent and how that might be different from some of the other terms that we've used?
I can try taking a crack at it. So the difficulty is, as we've kind of heard, there isn't like a definition for it. There isn't really as many like formalized trainings. I think we're kind of starting to see the beginnings of it in medical education, but it's kind of at its infancy. So I would say on the medical side, for someone who is trans competent, I would say you would have to at least like understand the basics of gender affirming care. So at least, and I think to kind of add to the definition that Lee gave, gender affirming care as kind of like a care approach is obviously, I would say, like, centered around informed consent, meeting the person where they are, kind of respecting people's autonomy in terms of their like self-determination, like kind of believing people when they're like, this is my experience. Great. We never question cis people when they're like, I'm a boy or I'm a girl, right? So why would we question for anybody else? And gender affirming care, when you see it as like GAHT or GAC in the medical literature, usually refers to hormones or surgery or some other like medical procedures to help people align their external presentation with their kind of like gender experience on the inside. And sometimes we might think of it as like addressing dysphoria or working towards gender euphoria, whichever framework you would like. But I would say for a provider to be transgender competent or like trans competent, like they would kind of have to have understanding of all the basic medical procedures available to folks who might be coming into your care, to be able to kind of counsel people, even if you're not going to be the one who's prescribing these medications. Obviously for a psychiatrist, that is not within my wheelhouse. I would say that is pretty much outside of my scope of practice, but I should be able to talk to people enough so that they feel ready to go talk to a medical doctor, like an internal medicine doctor, an endocrinologist, or to see a surgeon and say, I think I have generally realistic expectations for what this procedure or medical, or like what this medicine could do. I would like to start it. I understand the risks and benefits, or here are my questions to kind of have a more detailed conversation around this. So that is what I would think of within a medically specific context. But I don't know if the other panelists would like to take on what it means to them in their specific spheres.
I would just like to add that I think sometimes people forget being trans competent is an action. You don't go to a singular training and all of a sudden you are trans competent. Even I have to continue learning and educating myself. So it's really about cultural humility in a large way, and recognizing that you have to continue learning to be trans competent. But I agree with everything Heather said as well.
Yeah, I would second everything that both Heather and Layne said. I think that for me, the easiest way, because I work on the intersections of trans and intersex competency and justice work. So that's a little kind of background for that. A lot of the conversations that I have with people around both self-determination and just like gender and body diversity is looking at it from the vantage point of every single person knows who they are better than anybody else, right? Regardless of what the topic is. If it's about themselves and it's intrinsic to them, they're going to know better than somebody else. And also that every single person has a different body, right? Every single person has a different body. Everybody has a different need. Everybody has different things going on with it, different endocrinology, different combinations of body parts, different combinations of organs. They all work in different ways. Those things can be combined in different ways with people. And there's unfortunately a huge deficit in the medical field around education around body diversity, and endocrine diversity, and chromosomal diversity, and all of those things. And that plays both into trans competency and intersex competency, right? So with the example Heather gave as a psychiatrist, as a trans competent psychiatrist, you can't prescribe testosterone, but you would know that prescribing a stimulant can interact with testosterone in a way that might increase blood pressure. That's something that you would know as a provider who might prescribe a stimulant to somebody, right? So there are interactions and there are things pertaining specifically to gender affirming care and specifically to trans people's bodies that every provider should know if it affects their field of competency. So that's the other part of it. Yeah, so it's the respect component and also just constantly working to advance your knowledge of and fill all the gaps that are put there by a system that teaches you that there's two genders and they all look this way and that way. And these are the two ways that bodies can work.
This is like not a metric that is quantifiable anyway, but I think for myself, when I go see a doctor, like if I don't have to educate them about like trans specific medical care, like that is, I would say, someone who's a good trans competent doctor, or someone who is at least like understands the basics, and if there is a more niche topic that comes up, is like willing to learn.
Yes, I appreciate that piece of not only the knowledge of how to treat a human, but also to treat the medical needs that that person might have. And I so appreciate you both for speaking on that. And I know that I had a question come through a while back. I know, Heather, it seems like a lot of these are coming to you from a psychiatric point of view. I hope that's okay. But I know that other folks might also have their own take on that too. Can you talk a little bit about gender dysphoria in the DSM? I know that in order to receive gender affirming care, patients often need this diagnosis, and this can increase stigmatization or contribute to the misunderstanding that being trans equates to having a mental illness. Thank you, Madeline, for that question and for the additional information that you added on the back end there too.
Yeah, gosh, how long we got? I feel like we're talking in of itself, but gender dysphoria, this is a new diagnosis as of DSM-5, which was, I think, 2013 or 2012. And it replaced gender identity disorder, which was DSM-4 and then DSM-4-TR. The point was to try to focus on the distress, quote unquote, that a lot of individuals feel about their body when their external appearance and their internal sense of gender identity doesn't match up. That's kind of the textbook definition. And the decision to keep any sort of gender-related diagnosis in was pretty political. Obviously, DSM is from the American Psychiatric Association, based in America, where we have insurance-based healthcare, where all provision of care really needs to be linked to a diagnosis. So that's why you get like kind of absurd things like pregnancy is in an ICD-10 code, right? Like pregnancy is considered like, you know, I suppose if you took this kind of way of approaching things like would be an illness, you need a pregnancy diagnosis to get prenatal care, to get perinatal care. But the fact that it remains in the diagnostic statistical manual of mental disorders is pretty stigmatizing, because we already pathologize non-cisgender, non-cisnormative gender identities, people who just don't fit into the specific binary. But the big concern back then was that if there was no billable diagnosis at all, if we went from gender identity disorder to nothing, that would lead to a lot of disruptions in care, because there's nothing more than insurance companies love than cutting off people from care. The new development is that there is now the diagnosis of gender incongruence, and I believe ICD-11 or ICD-10, I forget which number we're on now. But that is interestingly under the sexual health section. And that one, I suppose, the attempt is to be less stigmatizing. More insurances are moving towards covering procedures based on that. I'm not sure what percentage or what that looks like in reality. I've met some endocrinologists and some doctors who bill under unspecified endocrine disorder to provide hormones in order to get coverage, to avoid that kind of diagnosis entirely. I personally just try to be as upfront about it as possible. I never try to bill under gender dysphoria unless the patient specifically requests it, or if it's for surgery letters or referrals, I will specifically discuss that hey, is it okay if I bill under this diagnosis? This will be required for your insurance. This is what I need to put in the documentation, just so that they can either say, no, I'm not comfortable with that. We need to figure out a different way to go about it, or yes, I do understand who's going to be able to see that, what that leads to, or what the implications are.
Thank you. That amazing. Thank you for covering so much I appreciate it. And thank you for bringing up also the fact that informed consent, if we are bound to these systems and have to use specific words and language, that we can at least speak to each other and communicate that is maybe part of the system, but that that you have their best interest at what you're doing and why you're doing it, to best serve them within a system that can sometimes be flawed. Sometimes it's an understatement. So thank you, Madeline. Madeline sharing back. Thank you for this answer. My partner is trans and needing this diagnosis to get access to testosterone, and it was really distressing for them. I just want to spread awareness, and I appreciate you. So thank you so much for covering that topic, and thank you, Madeline, for sharing some of your experience. I know we have another question about minors, which is obviously a very specific question right now in the United States. And I know, Heather, you do that work with youth, but I know that part of Trans Haven is working with whoever comes to you for support, and also in the Office of Health Equity. We have a question from Anna asking about how do we support minors who are transgender but haven't started medical procedures and are facing pressures either from their families or from cultures. We have a second half, but I'm going to just ask that first half to start off with, because that's a big question in its own right.
I think just not treating trans youth as a monolith is a good starting point. All of them will have different needs. Most of it comes down to being listened to. When I worked in the clinic, we would see trans kids who were obviously too young to even consider blocking puberty, for example, but the fact that they could come in and talk to the providers and know that they had options for when they did get to a point in their life where it might be appropriate was really crucial to helping their mental health care. So just letting them know, you hear them, you're listening to them, there are resources, and we can explore those resources.
Yeah, to the point about like facing pressures in families and cultures, I'm not sure which pressures you mean, like pressures to go through medical treatment or pressures not to. I'm assuming not to, because that's the more common one. I think one of the most helpful things, right? There are two kind of buckets of people that are helpful to identify. And this is something that would apply to pretty much any trans person, not just youth, but especially impactful with youth. Do you have any family members that are supportive? Or do you have any members of your community that are supportive, right? Because cisgender adults typically only listen to other cisgender adults. A lot of the time, right? No matter how much experience I have, no matter how much work I've done, if I'm talking about trans stuff and somebody finds out that I'm trans, like immediately for some reason, my expertise on the question gets canceled out for a lot of people because I'm biased, whereas cis people aren't, right? So there's a lot of benefit to finding community members that share the same culture, that are in the same family, that are supportive, either just as somebody to go to as a young person whose bodily autonomy is significantly limited by the adults around them. And also to see if those people can have an impact on the adults that are like making the immediate medical decisions for that young person. So that can be helpful. The other thing is, do you have trans friends? Do you have trans community? Do you have people that you can connect with, that can empathize with you, and that you can talk to about this stuff? Because it can be very, very alienating when not only are you surrounded by adults who are limiting your bodily autonomy and misgendering you, but also when you don't have people that you can relate to, from your own population within your own age group. So those are the two questions that I would always ask, to try to identify who's in their corner. But besides that, acknowledge that it really sucks and it's very unjust. And a lot of people go towards being like, well, you should try to understand the people in your family that are being transphobic, and it's hard for them to. You've probably heard language like everyone's transitioning. No, they're not. They're not. Only the trans person is transitioning. That's weird. But just being a space where somebody doesn't have to hear that over and over again, and being a space where the needs and feelings of the people that are making decisions for them that are ultimately not great decisions for them, where those feelings aren't being centered.
Totally. And I'd say also, I know that this is, again, very much stuff that we spread around, but to say it in this situation, along with many other situations, that there are, even if someone doesn't have someone in their physical proximity, that there are resources that can be utilized online safely. And obviously there are some pieces to that cybersecurity that parents might put in, but considering if you have a safe computer or device to use that you can utilize, I know the Trevor Project has their own and Trans Lifeline. I know, Kirill, you have worked with them in the past. So having different opportunities to, even if you don't have someone in your physical proximity, that thankfully through the internet, there is a lot more resources that can be used, and a lot of them have safety that can be built in. I know that, for example, like the HRC website, if you're doing research, you can press escape 3 times and it will completely send you back to a neutral web page, so that if you are in a situation, if there's a child in a situation where they don't feel safe, that they can utilize some things that might have extra supports for them in, finding a place and a time that is safe for them to share where they're at. And I also would think that I've been trying myself to redefine the coming out versus like letting people in. I think that that's also a helpful way to think about it if you are, talking to minors, in that they don't have to come out just because XYZ, medical procedures, etc., that they can be safe and keep what they need to keep safe for as long as they need to. And then when they feel like they trust someone in their community, or they feel like they've found someone who can be in that place, that letting them in to know more about their identity. I think coming out can be very, very performative and very challenging for folks who have to come out. That there can be, kind of thinking about it as like, if you get to a place where someone can come out to you and to share and to, look for your support, that is a huge point of pride for you, that you are creating a space where someone feels like they can trust you. So I think that also looking at it in supporting people is that you are being given a gift of trust. It's the same, I think, as if somebody from a marginalized group is coming to you and telling you about the experience that they're having, that they trust you enough that they will tell you something that could potentially be stigmatizing, could potentially be dangerous, that you are then in that space where you are, honoring them and they are honoring you with sharing that information. And that I think that pressures can be from elsewhere, but that you and your relationship with that person is the one thing that you have to handle in that moment, and to be there for them is the highest honor. So just want to add that one in there too, because I feel like that can sometimes shift a mindset when you're talking to folks who may not have, come out or identified that in themselves yet, but just creating a safe space in the way that you talk about things can also be huge. I know we had a second part to that question, but I think that, let's see. Okay. That's a great question. Some minors that Anna was mentioning would also shared that they would opt for self-medication for hormones before they could afford medical care. And so just looking for suggestions about how to approach that issue. Now, that's a complicated one, but I wanted to put that out there as well, if anybody had a thought on it.
I think that would be a really important thing to kind of discuss frankly with the parents. And the way that I approach this is I tell all the adolescents, all the kids that I work with, like, what do you feel comfortable with? Like, even if you want HRT, like even if you want hormones or top surgery right now, like, how hard do you want me to push with your parents? Like, do you want me to try talking to them alone? Because I don't know what it's like for them to be in their house with their parents. And I think they have the right to kind of like set the pace, and I will do as much as I can to help get them what they need at the pace that's, feasible, right? I can't move mountains sometimes. But for some kids, like, who are pretty savvy, who know a lot better ways to get hormones that may or may not be coming from who God knows where, like, this is a real possibility. And I think I would, talk with the parents, as long as the kid was okay with me talking to the parents about this. Like, we could either get you in to a medical clinic where your child is going to see a doctor, have regular checkups, regular lab work, we'll be able to monitor levels, like, versus your child could just go buy this online and get no levels, no medical checkup, no supervision. And this will be like that. One of these options will be much more dangerous. We know has much more negative outcomes than medically monitored gender affirming hormone therapy, which is one incredibly safe, linked with all these positive outcomes, including, decreased suicide, all that sort of thing. I think for parents, like, even the most supportive parents who want to do right by kids do often have a lot of questions that are embarrassing to ask in front of kids. That gets a lot of eye rolls at the best. And then sometimes just, you have all the arguments and fights that happen. Giving them the space to ask all these questions about medical treatment or about surgery in a private space where they're not going to bother the kid, where their kid isn't going to be judging them or getting so frustrated they're even asking all these embarrassing questions that, Mom, I can't believe you don't know this already. That can also save face for both parties. Be like, oh, I talked to your doctor and they seem pretty knowledgeable, and now I feel comfortable magically despite you telling me literally everything that the doctor has already told me in this hour visit. But yeah, I mean, I think for parents, like, to understand that, like, risks and benefits of treatment is important, but the risks and benefits of not treating is also an important conversation to have.
Thank you. And that's when you're looking at evidence-based practices, right? The data backs up that there is incredible benefit to being there and to making it a safe and informed decision on all parties. And I think that your point about the, safe or unsafe, you have the choice in that moment as a parent to be supportive and to, ensure safety above all. And that, I think, is what parents are generally looking for. But I think that is a fantastic answer. And I so appreciate that nuance that you're able to bring, because there is no way to have a conversation in front of youth that is not embarrassing for parents or for youth. Knowing that from working with youth before, it's impossible. It's always embarrassing. But I appreciate that having those separate times to discuss is a great tactic to utilize and a good strategy. So thank you so much for answering a complicated question and a more extended question. So I want to thank you very, very much, all three of you. I'm looking at the time. We have a little bit of time to, and thank you, Anna, for asking. We have a little bit of time to do our closing remarks and closing out, but I wanted to just give everyone a moment to, I know that it sounds silly, but there's also, there was a question that I forgot that would be a great answer, ending question. Are there any specific program exemplars for trans folks in Connecticut or in the New England region that you would want to shout out and bring attention to, that we could then also put in our resources that we send out to folks after this event? We've already got PeerPride on the list, and we've already got Yale on the list, but I wanted to make sure that there's also, if there's any spaces for folks to share.
Not so much a medical space, but a social space. There is an organization, it's a nonprofit called Q+, and it's specifically for LGBTQ youth. They do social events across the state. They're mostly in the Hartford area, but I've referred a lot of trans youth there, and it's been really good for them to connect with others. So that's called Q+.
Okay, I think I found it. So I'm going to throw that into, thank you, Kirill. I'm going to put that website into the chat. Thank you for sharing that, and appreciate that. I know that we had a question about the recording, so just to get that on everyone's attention, the recording will be up and shared with related resources within 48 hours of the close of today's session, and that will be available on the MHTTC website and will also be sent out via email. I see, Heather, you just added one in there. Please tell us more about Family Project.
Family Acceptance Project is from, I think, University of Southern California, but it's a wonderful resource for folks who are not so, for families who are not so accepting. It comes in lots of different languages, but the big kind of central premise is family acceptance is like the biggest determining factor for suicidality in trans and non-binary youths. Like, if I gave you a medication that would decrease your risk of suicide by like 10-fold, you would take it, right? There would be no question, but it's not a medicine. It's literally what you do for your children. So I think it's a really helpful resource for families. It's specifically geared towards like cultural or like religious objections. You can have posters up. All of the materials are free and easily downloadable.
Thank you. That's fantastic. I definitely have seen that before. And so taking a look, there's Spanish, Chinese, and specific other ones. And so appreciate you sharing those ones. Want to give space to Kirill, who shared Callan Lord, and maybe want to speak a little bit about that before we move on.
Yeah, so they're in New York City. They have a program called their HOT program, which is Health Outreach to Teens. So they specifically work with LGBTQ adolescents and young adults. I think it's like 13 to 24. And it is medical specific, but I think they do some groups. And everyone that I know who's trans, who's been part of the HOT program, has really enjoyed it and had a really good experience there. Actually, my partner was part of it and my colleague, so it was cool. Yeah, I would also second Q+. We're like a Venn diagram in Connecticut where they're all LGBTQ youth, and like only youth, and we're only trans people, and we have this little like overlap where we're constantly sending people to each other. Like, oh, they have a kid who wants to do only trans stuff because they're trans, or we have a kid who wants to do only youth stuff. So like we're always sending people each other's way.
That's amazing. Thank you for sharing that. There's one from Marysville, Ohio, free weekly meetings and monthly events for LGBTQIA plus teens called Under the Rainbow Art Club. Thank you for sharing that. I know there are resources throughout, so if you have any, feel free to throw them into the chat as we close up our meeting so that there would be other people able to take in those resources and to spread them throughout, because as we were saying, the communicating this and spreading awareness and also resources is incredibly helpful. And thank you, Kirill, for sharing that PFLAG resource. Want to thank you all so much for answering questions, for chatting with me today. So appreciate all the work that you're doing, and especially want to offer you a very happy Pride Month, despite and without and throughout what we're working on. I value so much the care that you put out into the world, and wanted to thank you from the bottom of my heart. And we'll transition over to Maria for a little bit of our closeout. And again, thank you so much. Throw your fantastic responses and thank yous into the chat, because I know that I've learned a ton from this conversation. So thank you so much, Heather, Layne, and Kirill.
Well, thank you. Next slide, please. Thank you all for coming, especially the presenters. I mean, really amazing conversation. What we would like to do in behalf of the New England Mental Health TTC and specifically the READ, just to extend thank you. We will continue, we will share perhaps we will figure out a way to share the responses in a way that you can all benefit. Our mission is always to be able to connect with each other and share resources.